Good evening, everybody. Welcome to this community conversation on Medicaid and people with disabilities. My name is Paul, and I'm going to act as the moderator tonight. We have okay, there we go. Can everybody hear this? Okay, great. So we have a plan to work through a panel and hear different perspectives, and then engage the audience in questions and conversation about this topic, which is complex and changing all the time. So very much looking forward to the exchange here. And as always is the case in the month of August, those dog days of summer, we have planned 4 panelists. We didn't want to wait too much longer, maybe a third or fourth we'll be able to show, but there's some changes in the schedules going on, so we're going to proceed and just adjust on the fly. But the intent here is to hear for 15 minutes or so about different perspectives and different topics here, and then come back and have that conversation. So our 2 speakers that are here at the moment, Carl Van Beek was an attorney with Barnum, still works with them on a modified basis today, and he's going to be able to give us a perspective about how employers see this topic, both from the past and in the current environment, and also addressed some of the cost shifting that's going on right now. Very important, obviously, towards the future role of Medicare and Medicaid. And then Kurt Freund is also a very experienced counselor in this area. He's currently working as a Medicare certified senior consultant, but through a long career as counsel on a variety of topics in financial affairs and working with seniors and so on. So he'll have a perspective for us on how Medicare and Medicaid are affecting persons with disability from the current and into the future status. So these ought to be very interesting. And I won't try to preempt anything. So Carl, if you kind of kick this off for us and give us your perspective. Maybe if we end up with the 2 of you here, we can ask some questions right after Carl speaks so that we don't have to hold those off. Maybe change a little bit. So take it away, please, Carl.
Okay, well, I'm glad to be here and have a chance to chat with you. I'm going to start with kind of a 1,000-foot view, and then I'll take it probably up to 10,000 or more, just to kind of give you a sense of what I, at least am generally familiar with. At the 1,000-foot level, my son, who went to Hope College, had a roommate who has cerebral palsy. And so I kind of learned some of the disability issues by osmosis, hearing my son talking about that and talking with that individual from time to time. I talked with him yesterday, just to kind of get a sense again of how he sees the world as a Medicaid beneficiary. He's a dual eligible, both Medicare and Medicaid, but as I'm sure most of you know better than I, that doesn't mean that he has a good system or a well-paid system or good care for that matter. So I'm generally familiar with some of his frustrations that he's experienced over the years in that role. He was one of those babies who was probably oversupplied with oxygen and ended up with cerebral palsy as a result. So at that level, at the 1,000-foot level, I'm sort of generally aware that life is no easy thing, no bowl of cherries for people with that kind of problem. Now taking it up to the 10,000-foot level or beyond, which I guess is why Dave Plakowski had suggested that I be one of the speakers here today. In my role representing employers throughout my career, beginning in the early '60s at Varnum, and particularly during the '80s and '90s, was constantly frustrated by the problems that healthcare was creating in the employer-employee relationship. Now, Lori, who's sitting here in the front row, and I have been acquainted and friends for many, many years because we've seen each other in different roles. He was the Alliance for Health, and in my role as an employer representative, we were constantly sort of rubbing shoulders and at times bumping heads as we were trying to figure out what do we do now with healthcare in this region and in this area. And always finding ourselves in a frustrating situation because healthcare became the major problem in the workplace. For no good reason, except we had the legacy of the War Labor Board of World War II, where somebody decided that employers couldn't raise prices, they couldn't raise wages, but they should be able to provide a complete healthcare plan to anybody who was working. Because some clever lobbyist convinced the War Labor Board in 1943 that a healthcare plan would not be inflationary. And a 1943 healthcare plan was not inflationary because there was a fixed price for everything. I read some of those old 1940s plans and early 50s plans. Everything had a price. They used the California schedule for all the surgical things, and all the other things had a fixed price in the schedule. So I remember reading, for example, in 1943, we probably had a 16-bed ward in the hospital, and the cost for that could be looked up. It was probably $8 a day. And if you were getting an appendectomy, that cost $12 for the whole procedure. A hysterectomy was $18. You can look up the price, that's my point. And everything had a fixed price, and it was not inflationary. What happened? Along came the '60s, when Blue Cross, to its credit, figured out that there was a way to try to deal with something like that, where they would say, rather to an employer, now look, rather than bargain the rate, I used to sit up all night and argue whether for a 3-year contract you'd have $81, $83, and $85 as the cost for the room rate in the hospital. Blue Cross said, well, what we'll do is we'll pay whatever the semi-private rate is. And you, employer, will pay the premium on whatever the semi-private rate is. And then for the doctor, Blue Cross said, we'll start covering the usual customary fee, whatever that is. So all of a sudden we had no limit on what the healthcare plan would cost for either the hospital or the doctor. Because we had a reasonable customary fee for the doctor and a semi-private rate for the hospital, and there we went. And frankly, that's when inflation on the whole thing really took off, because there wasn't a limit on cost. Now, from the employee's perspective, that was great, because whatever it cost, the plan was supposed to pay for it. Then we started to realize on both sides of the table that at some point, employees were going to have to start paying either part of the premium, a copay, or deductible, or all three. And we got into the confrontations then of the '80s and '90s, because part of my job and part of the job of the employer was to convince the worker, the employee, you've got to start paying some of this cost or we'll bankrupt everybody. And then, as we were talking here a few minutes ago, in the auto industry in particular, the big three controlled most of the auto business in America, were then caught trying to pass on the cost to the supplier, who then had to pass it on to the employee. And every strike that I knew about in the 80s and 90s, and I knew about a lot of them, some I was involved in myself, every one that I knew about that everybody else had, in fact, it was caused by healthcare. It had nothing to do with the workplace. So that was the dilemma we found ourselves in. Well, then, I've been active with the local Grand Rapids Area Chamber and the Michigan Chamber in my role as an employer attorney. And we started trying to figure out and dig into some of the costs. I said, why do things cost what they do? And we stumbled on the fact that one of the big reasons that the cost was so high was because of a cost shift. I'll explain that in a little more detail, but basically what we found out was that because Medicaid was not paying the full cost of the services that the state required, little by little by little, that cost started getting passed on through negotiations between the hospitals and the insurance companies. That it started in around the late 80s when Congress couldn't pass a budget. And they got the idea that what we'll do is we'll just pay the hospitals and the doctors 90% of what we paid them last year till we figure it out. And they passed a continuing budget resolution, pay 90% of the cost until we figure it out. They never figured it out. Because what they found out was that the providers kept providing at a 90% level. And then the providers were starting to eat some of that cost. It kind of went from there. And today, most doctors are paid somewhere around 60% of their cost, not of their charges, of their cost for Medicaid patients. How many of those would you take? Not very many, because you can't afford to take that many, because you are basically subsidizing the whole program. Now, that's kind of the overview of where I'm going with my remarks. Now, what I'm suggesting as one remedy for this is prioritization of benefits. That idea was started by Dr. John Kitzhaber in Oregon, who was the medical director of the Medicare, the whole medical program for Oregon in the late 80s, early 90s. He, by the way, was a Democrat, or is a Democrat. He got that idea passed in the legislature that what we ought to do is say to the legislature, look, your job is to pass a budget for Medicaid, because you can decide how to compare the importance of Medicaid with corrections, K-12, highways, everything else that goes in the budget. You don't know how to manage a medical plan, legislature. You just decide how much money there ought to be for Medicaid. Stop. Don't micromanage. Then Kitzhaber got the idea. There were, at that time, around 930 codes for everything that happened in the hospital. So what we'll do is prioritize those based on clinical and cost effectiveness. Those are the two ideas: clinical effectiveness, cost effectiveness. And we'll have an expert commission of 11 people figure out, among those 930 codes, what's most important and what's least important. So the first part of that is pretty easy. The commission found it pretty easy to agree, for example, that prenatal vitamins for mothers were important. Fine, we got that one off the list, and we'll call that number one. And they worked their way through everything else based on clinical and cost effectiveness until they got to 930. So now we had a schedule, a priority schedule. Now what do? The legislature said we have, pick a number, $6 billion. We will then hire an actuary to tell us what $6 billion will buy. The actuaries had all of the procedures in the computer already, and they knew the demographics of the Medicaid population based on how many women there were, how many men there were, what their health likelihood was based on other conditions. And they said, okay, early on, it started out saying, okay, this year we can pay for about 89% of those benefits, the $6 billion. So you say, well, what happens to the other 11%? Well, the doctors weren't going to be paid for them, and the hospitals weren't going to be paid for them. So by and large, they weren't done. But they weren't that important because based on clinical and cost effectiveness, the other things were more important. And then here's an important idea. Kitzhaber got the idea that we will pay the actual cost of the benefit. So we're only going to pay for the ones we can afford. We'll pay the provider their cost. Wachowski just came in and he's smirking because he knows where I'm going with all this.
Hey, I'm all right. No smirk. It's a joy to see you at my house.
Dave and I have been friends, because he's been active with the Chamber of Healthcare Committee almost as long as I have, I think. And we're also friends from Rotary, where annually we cut his hair. That's one.
Twice every 2 years. Sorry.
Every 2 years, is it? Okay. He's been trying to get me to have mine done too. Good luck. But anyhow, I digress. The idea was only spend the money that the legislature has and pay the actual cost to the provider. Those are both important ideas. By paying the cost to the provider, you didn't have a problem with what? Access. Because the doctor was going to be paid, the doctor was willing to take a Medicaid patient. Not a problem. So those are two important concepts, and I mentioned this, that why is this important today? Medicaid is the fastest growing part of the state budget. Medicaid started out to be a 50-50 program between the federal government and the state. Early on, the federal part of it was growing because the state, frankly, couldn't afford its share. In order to keep the thing going, the feds started paying more and more. And for states like Michigan that had a very cyclical economy, they recognized early on the state would find it hard to pay its 50-50 share. So the feds started paying more and more. Was that a good or bad thing? Depends on your view. Because with those federal dollars, guess what? A lot of strings came along. The federal government, through the years, basically demanded the right to determine what the benefit structure would be in the whole country. And if you wanted to be something else, you had to get a federal waiver. Oregon got its first waiver in 1991. And what was the waiver? The right to prioritize the benefits. Dr. John Kitzhaber got that. Pushed through. It took him 3 years under George Bush I to get that approved. But then he at least could control Oregon's Medicaid budget. That idea was so popular in Oregon that Dr. John Kitzhaber became elected governor 3 times. First, right off the bat, I think in 92 or 3, became the governor, re-elected a big majority because it was popular. And then he was out for a while, got re-elected at age 82 as governor of Oregon again, because this idea is popular out there. That's how it got going there. And I would encourage you, if you're interested in knowing about this in more detail than I'm going to go into, Google Oregon prioritized list. It pops up and it explains well on their website for the state. And you'll see how it goes. Now, Oregon has done a lot of interesting, sometimes strange, things in healthcare, which is why it has kind of a goofy reputation in the Michigan legislature. But they still have the prioritized list. They still have a commission of 11 people. Every 2 years, they review the list. And there's some jockeying that goes on, politically jockeying, lobbying. But it stays basically as a prioritized list. Now, what are the benefits of prioritization? The legislature has a simpler job. And given the term limits that we have in our legislatures, let's face it, that's about all they can handle. By the time they start to understand what this is really all about, they're gone. But at least this would be a way for them to do what they understand. How do you compare the needs for Medicaid with K-12 education, retirement benefits for state employees, all the other things they have to do, corrections, all the things that go in the general fund budget? Who knows how much the Michigan legislature's budget is in total? You can't answer that. Were you gonna say 56 billion?
I was gonna say 55. I was. Is it 56 now?
I think it's 56 billion.
All right, well, we're only
But
percentage off.
A billion here, a
Yeah,
billion
what's up,
there.
Kelly?
That's right.
10 billion of that is the general fund. Think about that. The 10 billion is really all the legislature does do anything about. The rest of the money, the federal earmarks and dedicated funds for particular bonds and that sort of thing, there's only 10 billion that the legislature can do anything with. And there's a lot of pressure on that 10 billion. Because some of you may remember, we tried to pass a road bill a couple years ago, didn't happen. And the legislature said, we'll do it, we'll pass that. But now they have to get 2 billion out of that 10 for roads. The amount that they can do anything with is shrinking and shrinking and shrinking. But their job is to pass the general fund budget and figure out how much Medicaid can get from that 10 billion, and it has to go up, let's face it. Now, the beneficiaries, well, you all know what an actuary basically does. An actuary takes the demographic data for a particular group of people and then says how much benefit you can get from the money available for that particular demographic group. They know who the Medicaid population is. They could, in a couple of weeks probably, Milliman could tell us how much we can buy with whatever the legislature passes for our Medicaid budget. Excuse me. Now, the insurance companies, frankly, are getting a windfall right now. With Obamacare, they really started to get a windfall because the hospitals really got a windfall. The happiest people about Obamacare are the hospitals. Of the people in the industry, they were the big winners. And then, because all the insurance companies basically do is pass on the risk to somebody else, the insurance companies years ago figured out that they can go to the hospitals, they can up the amount for the Medicaid shortfall and get that factored into what the hospitals get through the insurance companies, and that's how the cost shift happens. So right now, the insurance companies are doing fine, the hospitals are doing fine. Who's not doing fine? Whoever is paying the premium for healthcare. Whether it's the employer, or if you have an individual policy, there is a 20 to 30% write-up in the premium to cover the cost shift for the Medicaid underpayment. Because the state pays 60% round numbers of what doctor's cost is, and give or take 80 to 85% of what the hospital cost is. So they're both getting less than the real cost for the service they do. How do they make it up? It gets passed on to the insurance companies, and then anybody who has an insurance plan, whether it's an employer plan or an individual plan, is overpaying to the tune of 20 to 30% of the actual cost for their plan to subsidize the state for Medicaid. And what that really does is puts the insurance company in the business of being a taxpayer, a tax raiser. They pass on the tax to all the rest of us as a cost shift, and that's how the money gets laundered. Now, summarizing then, the legislature passes a bill saying, we think this year we have X billion dollars for Medicaid from the general fund, and we have many billions of dollars. Out of that $56 billion fund, 45% of the total is for human services, and the biggest chunk of that is Medicaid. And that has grown remarkably over the years. The legislature has nothing to say about the money that comes through the feds. The feds tell them, here it is, spend it on Medicaid, and you can't change the benefit. If you want to change the benefits, you have to get a waiver from the federal government. Waivers have been very hard to get. Michigan has gotten a few. When we passed Healthy Michigan, 2 waivers were applied for and approved. Those still exist. But Healthy Michigan also says, if the feds stop paying the shot for the Medicaid Healthy Michigan, it automatically is revoked. Legislature hasn't do anything. Federal say we're stopped paying for that. Healthy Michigan is gone. 650,000 people are now in Healthy Michigan in the last few years from a standing start. There are 1 million others in the Medicaid program. So it's 1 million of traditional, 650,000 of Healthy Michigan add-on. Total is 1,650,000 of Medicaid recipients in Michigan. That's the dilemma we're all living in. The legislature is going to have to figure out what to do whether or not Obamacare survives, and whether or not they decide to give us a block grant, for example. But those of us on the Chamber Committee have been harping for years, get ahead of the game. Start prioritizing the benefits so you can control it. Because whether Obamacare survives or not, even traditional Medicaid is causing the cost shift. Get used to it. So that's kind of my sad story.
That's good.
Thanks, Carl. That was a little bit scary, but
We tried to scare you a lot.
I appreciate that. And I would like to do a couple things here. Lodi, it's a pleasure to have you here tonight. I think that's kind of a bit of good fortune for us. So I hope that you'll join in on this and give some perspective. We'll come back to you maybe after Kurt speaks and ask you to comment on both if you don't mind. You can elect not to, but would you pronounce your last name?
Warrenstein.
Warrenstein, okay. And so just for the audience who don't already know this, Lodi was the past president of the Alliance for Health, which is a huge nonprofit in the area. And I know you have a lot of perspectives on all these things, so we'd very much like to hear that as part of it, if you don't mind. For just a pause moment, and then we'd like to open it up, I think, to a couple of questions right now, Carl, while this is fresh information. I'd like to get this started passing through the audience while we're in the Q&A portion here. If you'll take a minute and just jog down your name and email address, we can get information to you if you'd like it.
Yep.
I'd also like to make you aware, I think this is at your seats, that one of the contact points coming out of today's conversation would be the Michigan League of Public Policy. And so this provides some information on how you might reach out to them as a call to action coming off of the conversation. And I guess we'll come back to the big audience for questions at the end, but I'd like to say, does anybody have a specific question where the information is hot, or a couple questions to start the conversation right now on what Carl just talked about? Yes, sir.
When you say you're reimbursing a
Just
physician or a hospital for their actual costs, how is that
Oh,
determined?
Can we
We do
have-
want to get a mic to you if that's okay.
Yeah, for the people who are watching at home.
Okay.
Yeah, we're live streaming, which is exciting.
That's intimidating.
So if you could just say your name.
And then the question.
Steve Johnson. And the question I have is, you talk about reimbursing physicians, healthcare professionals for their actual cost. How is that determined? Because the actual cost would be very different here than it would be in Detroit or up in the UP.
I'm not a cost accountant, but I've poked at that question hard for a long time. And I'm understanding that because almost all of the healthcare in America is provided under federal programs, that there are in fact agreed upon definitions of what is cost in both a hospital and a doctor's office if they participate in care and K. I'll grant you that the costs are going to be different from one place to another. And there are huge differentials around America, as you know. But at least for each particular provider that has a Medicare license to provide, there are definitions of cost that can be used to nail it down.
And the money that would come from the federal government is carved up and prioritized every year? You're talking about federal government or just state?
The only place that has the kind of prioritization that I was talking about is the state of Oregon.
Yeah.
Sure, we all prioritize, and the federal government prioritizes a lot of healthcare already in terms of what they will pay for and how they decide what drugs will approve and all that kind. There's a lot of prioritization that goes on at that level. But the kind of thing I was talking about is really a recommendation to the state of Michigan to start prioritizing Michigan benefits.
Okay. And with new healthcare breakthroughs and treatments and stuff coming through all the time, we hear about different therapies for autism, et cetera, just a whole bunch. New costs are coming on because of new procedures. Does this budget grow to cover those, or we just see it incredibly shrinking in terms of actual what's benefit are deprived out or being paid for?
CMS runs both care and K.
Right.
CMS has created the existing list of benefits for both. CMS is the gatekeeper for the new therapies and the new drugs that come out, and they decide whether to add them or not. But frankly, you can't buy an insurance plan anywhere in America that has as many benefits as the Medicaid list.
I know, I've heard it's the best insurance you can't buy.
Exactly. The Cadillac plans in Michigan, Mesa for the public schools, there are a lot of benefits in the Medicaid list that are there that you can't find on those. As you folks know better than I, it's nice to have things on a list, but if you can't get them or you can't pay for them, who cares?
Then there's the non-medical things like attendant care, et cetera. A lot of those things are extremely important to people, but it's not really medical. So are those prioritized also?
In Oregon, they are.
Okay.
And they're allocated, I'll use that term, in America, in all the states, including Michigan, as to what they'll pay and how much they'll pay. You know, for example, for some kinds of care, you've got 4 hours a day, that sort of thing. Those are all determined by the feds.
I'm more concerned about the talk about capping. Okay, this is the amount of money you get when you run out of it. Too bad, Michigan, or whatever state it happens to be. You know, if attendant care is needed, we just ran out of money. Sorry, you got 2 months left, and you know, you're doing it on your own.
Sure.
It's not possible for some people.
And the state turns those things on and off like a spigot. You know, Bodie and I were both active with the old Kent Health Plan. And the state would turn on the spigot and give us 4,000 names and then turn it off. And then we'd try to provide benefits to those 4,000 people. Then as the year went along, if they looked a little better, they'd turn on the spigot again and give us 2,000 more and then turn it
I
off.
think you need a new plumber.
But yeah, the idea of prioritizing and deciding how much money there is to spend is not new. Both the federal government, state, do it all the
I
time.
understand you can't print money too, but if it all becomes a financial decision, what about the actual need? When you run out of money, what happens?
Who were you asking, state or
Well, the Fed was talking about capping it, right? Making grants to the state and then just, that's it,
That's one of the options that's being considered.
right,
Just giving a block grant,
block grant.
or saying, you got this much last year, we'll give you that plus 1%, or something like that.
And not all states are gonna, not all states will handle that as responsibly as others. So, that's scary.
So, I'm an old cost accountant myself, and, I know you can make, costs come out in many ways. Are you saying that in the prioritization, topic that you were discussing, that the federal government or the federal and state government would establish a common cost, or is that still going to be dealt with institution by institution? I know St. Mary and U of M and Spectrum all charge different amounts for the same procedure. So how does that get dealt with?
I can't give you a detailed answer, but my understanding is in Oregon, again, I'm just gonna refer to Oregon, that they know what the cost data is for each of the facility providers. So if, for example, there's an appendectomy, they know what an appendectomy at Saints typically costs. They know what it costs at Butterworth, they know what it costs at Logic. What the real cost is, and it varies from place to place, but they will then allow that cost for that provider, if I understand correctly.
Okay, yes.
Be very careful about your terminology. There's cost, there's charge, and there's what you get paid.
Just one
Can you
second.
wait till we get in there? We wanna hear this,
I
so.
don't know, would Brody wanna join the panel up here? Would it be open? Okay. There you go.
I would
Can I
say
clarify, because I may be mishearing, is it Brody or Lodi?
Lodi.
Oh,
Loaded.
I'm sorry.
Okay.
Go to what?
No, I just wanted-
Yeah, Lodewijk if you wanna be appearance. What I was saying is you have to be very careful of language, and one of the biggest problems we've had in dealing with healthcare is the fact that people can be led by the nose by terminology. Cost is the actual amount it takes to produce something. Charge is what somebody would like to be paid for it, and then payment levels are what someone else decides that's what it's worth to us. They're different. And you hear people say our costs are going through the roof. No, they're not. Our charges are. And, we don't get paid enough. Well, depending on what, and these are different terms. They are used to confuse, they're used to make sure you don't know what you're talking about. And especially in the negotiations, Carl has had over the years, those terms and the confusion of them has caused a great amount of problem. And it's allowed some people in the whole scheme of things to skate free. That's why Carl said there are some real winners. Hospitals will convince you that they're not being paid what they charge. Well, that's true, they're not. Are they being paid what it costs? Well, even cost accountants, I'd go a little farther, don't know what they're saying in healthcare because the history of cost or cost accounting is so imprecise that it's had nothing but upward pressure for no reason other than people wanting to be paid more. Let's gin up our costs so we can get paid more. It's a common thing. So again, be very careful, and the confusion still reigns.
It's a slippery slope. It's been that way for 50 years, well, 45.
So, from our audience, are there other questions that we can tap into right at this moment? We'll come back again at the end, but does anybody have an immediate question why this is sort of hot? Okay, we'll come back. Kurt, you're going to talk about sort of the current and into the future state of Medicaid and Medicare.
But more of the trenches.
Okay, so why don't you go ahead?
We have 1,000 feet, 10,000 feet. I think Christine wanted me to come in and
deal with what's happening with real life people, with Medicare and Medicaid, and real live people who have disabilities, is added on to that. Margaret and I have had a ministry. I'm a Presbyterian pastor, and left the pastorate back when I was about 45 to go into I call biblical finance, helping churches, pastors, and Christian families with their finances. This graduated into, when I went to retirement, into more of a getting out of the finance into the trenches of seniors and health coverage. That was an overlooked area. So right now I also do with the Presbyterian Church, Margaret and I, the older adult ministries. And there we're trying to deal with the church on helping people make the last third of their life, the best third of their life in serving others and serving the Lord. We found that the same kind of things that were affecting many seniors also affected persons with disabilities. Same kind of things. So it's a little different statement to help people with disabilities. They're not maybe in their last third of life. It's not a longevity thing. It's adjust your life to have purpose and serve others. So it's really having purpose. Doing something that has value for you and that makes you feel that you have value when life is throwing you some curves. You can play Ain't It Awful, or you can find a way to take lemons and make lemonade. That's what I think DAC is doing a great job with, is helping folks who have disabilities to do something beyond just feeling sorry for themselves. The disabled on Medicaid, I'm seeing as having, you were saying there's a lot of cost for Medicaid and it's going to get greater. I'm afraid there's going to be tighter scrutiny on Medicaid, and a lot of folks who have disability who can't work are also on Medicaid. So it's the disabled people with disabilities who are on Medicaid that I have a great concern for. Because there's a movement in Medicaid to start looking at people's eligibility out of their ability to work. Now, a lot of this, I think, is excellent because there's some scams going on where people who aren't disabled are getting disability. So there should be some screening there. But the idea that if you can't work, you need to do volunteer work or to further your education is also seeming to come into questioning about your Medicaid eligibility. We should be maximizing potential, even if potentials may be limited because of a disability. We offer options to persons who have disabilities to allow them to have purpose in their life and to serve others. There is something that's happening within Medicaid that many of you know about. It's called the spend down. This is the monthly deductible that is happening within Medicaid. I've seen them as low as $200. I've seen them as high as $1,200. But when you have people who are on an income of $1,400 or less, which is a ballpark figure for people on Medicaid, and you throw the average spend down seems to be about $500 to $700, where are they going to get it from?
Can you just clarify what you mean by spend down?
That's a monthly deductible
Okay.
that has to be met before anybody can get Medicaid health benefits. Which in effect is bringing many people who are disabled and on Medicaid to be self-insured unless they go to the hospital. Because if you have a $500-600 spend down or monthly deductible, and you're already living on $1,400 a month, where are you gonna get that? It's a real crisis. And it's bad for the low-income people who are on Medicaid, but how about the people who are having disabilities and are on Medicaid? They don't have wiggle room. They can't just, well, I'll just go take a second job or something like that. So it's really affecting, I believe, at a greater level, people who have disabilities. But this is great for government agencies. Because they can say, look folks, we've got folks on Medicaid, we have X number this year, we have X number this year. But look, our costs are less. Our costs are less. So we must be doing a pretty good job. What they're doing is carving Medicaid on the inside, and the benefits aren't reaching people who are on Medicaid until they meet this monthly deductible. And it's complicated. There's over 20 Medicaid designations. It's a very slippery slope. The term dual eligibility needs to be understood. Most of you know that. It's having both Medicare and Medicaid. If you're on Medicaid and you're under 65, you need to wait 2 years before you can get on Medicare, A and B. A is for your hospital treatments, B is mainly for your doctors, durable equipment, this kind of thing. There are 2 major dual eligibility carriers in Kent County. If they're Medicaid dual eligible, they have to abide by the spend down, the monthly deductible. So people who are on these dual eligible plans, Medicaid run, they're stuck with the spend down. What few people know is the MAPD plans, Medicare Advantage plans with this with the drug plan, are run by Medicare. Now you have to pay a premium for that, and you do have more built-in costs, but it starts paying the bills right away. So there's this flip for people who are on spend downs, and I'm increasingly putting folks from a dual eligible plan onto an MAPD plan if they have a spend down. It doesn't seem to make sense, but it saves them from really being self-insured to having a plan they pay a little bit for, but it pays right away.
Excuse me, if I can just jump in for a second. I want to just invite the audience in here. Is this the kind of thing that's affecting people in our audience tonight? Is Tammy?
Oh, yeah.
Yes.
Okay,
It's
right.
affecting the disabled.
Yeah, so, from my perspective, and I'm gonna fit into that disabled class, is getting a little into the weeds for me. Are there questions you guys have right now, based on what he's saying, that we can sort of bring this up a little bit in terms of a higher umbrella of discussion?
I told you I'd go to the trenches.
I know.
I don't know if I actually have questions, it's just
Can you wait for the microphone?
I'm sorry.
Thank you.
There's probably
Your
another-
voice is important to us.
There's probably another microphone around here somewhere, is there?
I don't know if I have questions, but I can absolutely, this is on, can you hear me?
Yes, thank you.
This is absolute, what, Kurt is saying is absolutely true. Because I'm one of those folks that was in that position, when I tried to apply for Medicaid, I came back with, and all, you know, in all sincerity and being transparent, I received no Medicaid services. I qualify for Medicaid services with, I qualify, but one thing stops it. My income is too high. And I believe I should be paying something for my health care because my income is higher, but it is a struggle. And Kurt is right. If I were not on a Medicare Advantage plan, I would be struggling. I was struggling because I needed medications and couldn't really afford them. It's what he's talking about is real, and when it comes to the spend downs and the personal income limits, that's even more real because my spend down at one point was, I think, $1,100 a month, and what that means is I figured it out once. If I were to do that based on my income, I figured it out. What that basically meant is I would have housing and nothing else. Now think about that for a minute. Housing and nothing else. No food, no medication, no transportation, nothing except a place out of the elements. And that's the real part of it. And the Medicare Advantage plans have given me the best access that I can afford at this time. Do I want more access? Yes. But to be honest, at this point, the access that I have is appropriate for what I need. But I am concerned about what's going to happen to me and other people like me as I start to age. So, do I have direct questions? No, but I can tell you that what he's talking about is real. It's very real. And the spend down issue has been an issue because I'm been around a while in advocacy circles. This has been an issue for over 30 years.
So 2 takeaways out of that. Did you have to do anything special to get on the Advantage plans at a certain time? Did that make a difference?
Basically, yeah, I had to go in an open enrollment, and I went to an informational meeting, and I just went just to see what the option was, and the way it was explained, and the reason that I did it is to try and cap some of the out-of-pocket costs that I would have. If it weren't for the Medicare prescription programs, I would be struggling. I was struggling before I had that.
So that in and of itself is a bit of a call to action. Get out there and
I was paying a $45, which I know in today's dollars doesn't mean much, but at one point, even with a Medicare Advantage plan, I was paying $45 for one copay for one prescription. That prescription has the amount that I have to take has been lessened because my health is tremendously improved, but the copay on that is now half, which really means a lot. But I'm not going to lie, I'm not going to sit and say that I'm not struggling because I'm still struggling. Now, some of that, let's be honest, is my own choices and there are consequences to that. But people are struggling. That's the reality, and what he's talking about is 100% true.
And one of the, there's called the special exceptions for, there's the open enrollment period, which is October 15th through December 7th. But if you're on Medicaid and you have a special exemption or exception, excuse me, it starts with an E, but I keep mixing them up. That means any month you can change your plan. So people who are on Medicaid can change to a Medicare Advantage plan out of a dual eligible plan. Or a lot of people, I'm amazed, they think all they can get is Medicare and Medicaid. They are unaware of the supplements that are out there. And this I might as well just say it, I basically, in Kent County, place people into Priority Health. Frankly, Priority Health is owned by Spectrum. And the 800-pound gorilla gives a lot of breaks to Priority Health. So their premiums are less, their benefits are better, they have the highest customer satisfaction rate, which means CMS, the government agency, reimburses them more money each year than the other companies. And I just have found they do an exceptional job. So
I could also, Bodie, do you have a perspective on these various different healthcare systems? Is Spectrum an advantage to the community?
that's a tricky.
I,
I don't try to beat around the bush.
let me say this, the 10 to 12,000 employees of Spectrum are trying to do a very good job each and every day. They're very dedicated.
23,000.
20, well, when you figure the whole system. The couple people in the C-suite, I don't think are that responsive to the public. I'll tell you, they're responsive to their own needs and desires. So are they good, bad, or indifferent? The care that's provided is fine. The financing behind it is reprehensible. They have a great ability to do a lot more of what they do for a lot less, but they also have ways of jacking up the prices. Remember, Priority and Spectrum are two sides of a lobbying duo at the state. If Spectrum isn't doing well, but Priority is, the Spectrum hospital folks will tell you the state through Medicaid is a piper. They'll tell the federal legislators, Medicaid and Medicare are doing a terrible job for us. On the other hand, there are other years where they'll say, oh, it's wonderful, we're okay, and Priority will do the complaining. Well, we don't get the reimbursement. One or the other. They're never both satisfied. They're always lobbying for more. And it's not because costs are higher, and it's not proportionate to the membership. It's just, we'd like you paid more every year. Why not? I'll give you something that gives you a view over the years. In 1972 and 73, you'll remember then President Richard Nixon instituted wage price controls in healthcare. Well, actually across the whole economy. They contracted that program out. And my agency was the local contractor for healthcare. Being the new kid at the time, I was dumb enough to say, I'll do that. I was given all sorts of materials, especially from the feds, on the ratios of various salaries, since we had to adjudicate desires for more wages. At that time, studies that were very well documented showed the average hospital CEO was worth about 4 times more than the average nurse. The average doctor at that time was worth 7 times more than the average nurse. Compare that to where they are today and you'll say, gee, what happened? And I've been accused of being an ultra-Calvinist on this, and I am. Greed has gotten into the system, but the only people who can apply the greed for their own good are the people at the top. Sorry about that.
No, that's a good perspective. Thank you. I have a question that I would like to ask, but I want to get back to the audience and ask, does anybody have a linkage between what we've heard before, a story, a personal comment? Because in listening to the three of you now, I have a question that I can link into
Well, the only thing I'd like to get back to the trenches on. I don't. You've been in the 1,000-foot, 10,000-foot level like here. I evaluate plans every year, and we're coming up where those plans. And for my clients, I look at the best price that you can get, the best value and the best customer service. Are they gonna have hassles? And that's why most of my clients I place into priority health, because they've got a tremendous track. They're the benchmark plan for Michigan. Legislature has named them that. But that doesn't say Blue Cross or Humana doesn't have a good plan. It's just what's the cost and how are they treated? That's the number one thing for people in the trenches. And all this stuff that's going here, I almost try to stay away from it because it's kind of ugly.
Carl, maybe I can lob one that links what you just said, Kurt, but bring it back to the employer too. So, for example, when you get a statement from one of the hospitals and through the insurance company, many of you will be familiar with this, some maybe not, but it starts with what the cost of the service was, and it works across a page that gives the insurance company discount, then what you get for a copay, and finally gets over to your side of the equation. You owe this much. It seems to me that I'm hearing a couple of things. Priority Health is really great at what they pay, but perspective that I have, having spent a lot of time searching through my own healthcare, is that Blue Cross pays pretty well. The marketplace plans, depending on what you want to buy, will sort of pay. And I end up kind of still looking at the thing as a cost accountant and go, Spectrum might be charging twice what Mercy's charging on this procedure. Maybe because Priority Health has the best plan, they got a bigger discount at Spectrum. But at the end of the day, I keep coming back to your point of cost. All this other stuff is, I don't know, magic. And my question to you, Carl, is why aren't the employers who really have the clout able to do more about what an insurance company is willing to pay? Why isn't the people that are really paying for this able to corral this in a better, more cost-effective way?
Well, that's a great question, and I wish there were an easy answer.
Yeah.
If you go back 40 years, employers were paying the full shot for almost all group plans. And that's why I mentioned during the 80s and 90s that had to shift, because, when we started explaining to certain unions that you should be paying some of the premium or copay or deductible, that's what caused the strikes. And the employers tried like mightily to try to convince the big insurance companies to help deal with that problem. Frankly, put it bluntly, the unions and the insurance companies were each other's best friend. The insurance companies took very good care of the union people, the leadership of the union, and the unions were the best salesmen for the insurance companies. That's how we got in the pickle we're in. Now, today, the employers are still paying most of the cost of healthcare in America. 60% of the people who have a healthcare plan at least have an insured plan by an employer. Now, the federal government, back up, government programs are paying 51% of all the healthcare in America. Of the other half of the program, employers are still paying the majority of that. Despite that, employers have been unable to get their arms around this in a way that everybody will work together on to stop the gouging. It's better than it was, I'll say that, but it's still out of our control, ours meaning the employers. The local chamber has been advocating for change in the Medicaid program for 25 years. We haven't made a dent.
Yeah. It's a conundrum,
I'll
question.
I'll take it another step. The Michigan Chamber of Commerce has been working on this problem for a long time. But let's remember who the members of the Michigan Chamber of Commerce are, and who some of the biggest ones are. The insurance companies and the hospitals. So it's very hard even for the local chamber to really take on the system, because who's the biggest member of the Grand Rapids Chamber of Commerce today? Who is the biggest employer in Grand Rapids today? Spectrum. So it's very hard to get pushback with real clout.
Carl, I was gonna tie these, my points to the question that was raised, the three types of fishing experiences. Is it okay if I?
If we can hold off 1 second, we'll come back to that, but I just
Okay.
wanna make sure our audience, if there are questions, I know we're trying to keep
Let me
the,
make one other quick
Sure.
clarification too. To its credit, Spectrum is one of the few hospitals around where when you look on their website what a particular procedure costs, there are three numbers. There is the charge, which Lodi talked about, is the price. It's sort of, the Art Van price
Sticker price.
for that mattress. There is the average amount that insurance companies will pay for that procedure. So if it's an appendectomy, here's a price for the appendectomy for the room at the hospital and the procedures. Then there's the average amount that all the insurance companies who pay Spectrum something are actually willing to pay, what they've negotiated. And then, this was to my surprise when I started looking at it a few years ago, there's actually the amount that Spectrum gets paid by Medicaid, which is a lot less than either of those numbers. That's why there's this cost shift I'm talking about. The transparency is there. You can find out what you as a Medicaid recipient are, what the hospital is being paid for your procedure. It's a lot less than either the cost to the insurance company or the charge.
do you think that consumers, by checking costs in advance, this isn't obviously something that could be done all the time, but when you can make an inquiry, whether it's Spectrum or Mercy or whatever, directly and say, what will the cost of my procedure be? Then they'll kick it back to the insurance company and you can get the actual number.
Yes, and
Is that
the idea of the educated consumer,
right?
the individual actually shopping for care, the way we do for everything else in America, is just, in my understanding, starting to take hold. There are studies now that are showing that for procedures where you have the time to schedule it, so if you're gonna go get a hip replacement, I'll use that as an example, you can actually now look around the country and your region to find out what it will cost you to do that. Where you can't do that is when you've got an emergency condition. And most people aren't gonna, if you're having a stroke, you're not gonna take the time to figure out where you can get it treated best or cheapest.
I know as a personal experience again, you end up, if I call Priority Health and I say, I want to have an MRI, this is going to happen, but I don't know where to go, they won't tell you. What they'll force you to do is make the institution contact the insurance company, give all of those codes. There are now 65,000 codes instead of 930. And it's institutional speak. And a week later, they'll come back and say, well, the cost will be X.
They're doing the negotiating.
Right. So is there a way through employers and the consumer that maybe the call to action is how do we, through whether it's through the League of Public Policy or some other venue, how do you get onto that team? Because the insurance company really isn't your friend.
What part of the problem, maybe you've got a better answer. If you have one, go ahead.
Well, I think the insurance company is the negotiator. In a sense, that is where they are your friend, but you're not capable of negotiating, they think. What we need to be telling them is, oh yes, we are, and we want a piece of the negotiations. Tell us how to negotiate, and that's really where I think we need to be if we're, again, getting into the trenches.
Yeah, and I think as consumers, though, it gets back to our negotiation comes at the point of crisis. I've got to have a procedure in 10 days, and I can't negotiate well in 10 days like I could in 10 months.
Right.
Okay, but the issue becomes if we're going to do something now on a bigger scale as consumers. And I personally, it's just a philosophy of mine. The insurance companies are not patients' friends. They're just cost managers. The patient friend is the health system, the doctors and the nurses and the people that are actually going to provide the value of care. The insurance companies are code managers and profit institutions. So they need to be worked on, whether it's from the employer standpoint or the consumer standpoint. How do we do that more effectively seems to be the issue that every patient gets confronted with, and there's not time to deal with it when you're in the crisis.
Part of the problem is, if you're talking about an employer group plan, for example, the individual employee is not the contractor for that plan. They're the beneficiary of it, but it's the employer who has the contract relationship with the insurance company. If you are single, if you are actually an individual who is uninsured and you're going to pay the bill yourself, and there are a few of those people out there, then you have some clout at least to try to bargain what you'll pay for. Otherwise, they won't talk to you.
Okay, I didn't.
Okay, well,
stop you.
I just wanted to address what Christine set out as the article, and try to open up a discussion about the fishing expedition.
Right.
The first school is to provide a fish. The second school is one I'm more apt to be in. Teach everybody to fish. But if you don't have a disability, it's easier to fish. How about the folks who have trouble holding a fishing rod? What I think we need to do is, because there's going to be less funds available, to make sure that even people with real disabilities, I mean, there has to be some weeding out of the system. It can't be a cross-cut. It's got to be selective. Those who have the worst disabilities, if the funding is going to go down, are the ones who need the help. Because I'm not seeing funding going up for Medicaid. I'm seeing it going down. I don't know if anybody has a better crystal ball, but when you look at the Affordable Care Act and what is going to be cut out of the Affordable Care Act, that's almost all these extras like Medicaid, and like you were saying, my family and my child, those kind of programs. They're just cut out. So we've got to screen those people who really have the disabilities. Then we've got to approach the community and the faith-based organizations to encourage them to do more. 50, 80 years ago, the church and the community kind of gave up a lot of the funding of programs for the least of these to the government. And they backed out, and they're kind of sitting on their hands. We got to awaken the sleeping giant. And churches, faith-based organizations, and community groups, this is the call to action I'm hearing that we need to get involved in. When I was calling around, an old friend of mine, anybody remember Bill Hardiman? By the way, Dave, he says hello. Bill Hardiman has been mayor, then he went to the state legislature, then he went and served veterans out of Lansing. Now he's with DHS. I don't know if any of you knew this. I didn't. And he is with the Office of Interagency Cooperation. And his focus is faith-based organizations. Another department there is dealing with the funding that the state is dealing with. Bill said, when I told him what we were going to talk about tonight, he said, let's talk, let's get involved. So the movement, I think, needs to be to work with government agencies as best we can to awaken the sleeping giant, to take the anticipated cuts in funding and make sure that our persons with disabilities are not left just out in the cold.
So let me jump on that. I think that's a good comment for sure. And I'd like to turn to Dave and Christine, and again, maybe to Lodi. Do you have some thoughts on how, from a jump on the bandwagon with organizations perspective, anything might happen as we walk away tonight? Is there?
Well, I mean, I would say first and foremost is, we're barely scratching the surface on this, and what's the level of some of those, again, instead of creating a university level course on this, which unfortunately you kind of have to have, but at the same time, why don't we? And as we learn this stuff, because I'm all in favor of faith-based organizations and other philanthropic organizations to help, but just in the area of long-term care, when Carl talks about what are the benefits of Medicaid, Medicaid pays for long-term care. It's $1.8 billion of that budget in the state of Michigan. And $1.8 billion is a lot of bake sales. And then to say that $1.8 billion, the last time I've heard the statistics is like 80% of long-term care and home-based care is provided like for free by family members. So people are already kicking in. And I know of one faith community in Grand Rapids that wrapped themselves around one family with one family member with MS, and the severity of that MS, it really knocked these folks, again, they are the best of intentions to help, and this is a good-sized church with a lot of people helping, and they were like, oh my gosh, are we not done yet? And so all of this, how are we really looking at how do we want to treat our family and friends? And then, and again, this thing called government, how is this part of it? Because when we start looking at bigger solutions, does all of this lead to a single payer? Without, maybe that's a whole other conversation instead of cracking it open in 5 minutes to 7.
Yeah.
But yeah. But I mean, to quickly go back to that other conversation, that, Carl and Lodi were kind of hitting to, we have to become more informed consumers. That ain't gonna happen. I'm the worst buyer out there, I negotiate terribly. And like, I'm gonna go out there and talk to the med station, hey, you say $50, how about $40? And they're gonna say, no, we got a line. Please get out of the way, sir. We don't haggle. So I mean, all of that, we've been taught not to be purchasers, and again, the purchasers that you keep saying, at least correct me if I'm wrong, Priority Health and Blue Cross, they buy the services, we buy the coverage. And then we pay our premiums, and we pay our co-pays, and we pay our deductibles. So again, all of this stuff, like how do we try to get educated so we can be engaged in this, as opposed to simply screaming, give us more?
Let me make a specific suggestion. I have not taken the time or been able to figure out, I've asked a few people if they did know, where the disability benefits in the Oregon prioritized list show up. And I think that could be an interesting study for someone to try to figure out where did the disability benefits for Medicaid in Oregon show up on that prioritized list? You know?
I don't,
Oh.
I have a question that has
Well,
to do
but
with that.
here's why I'm asking the question. Senator Mike Shirkey is the go-to person in the current legislature who really is interested in the prioritization idea. He has been studying this for some time, and he has decided that it's probably the best answer for how to control the Medicaid budget. It's not a question of saving money as much as controlling the budget. That's what prioritization allows you to do. Now, within the amount of money that's available, there are two times to advocate. One is to talk to the legislature about how much ought to be in the Medicaid budget compared to Department of Corrections, K-12, and other things. That's the kind of thing legislature can be lobbied about and can be listened to. But then if we are able to get prioritization to happen in Michigan, the way to advocate then is what? Make sure that the Medicaid benefits get the right priority in the list based on clinical and cost effectiveness. Those are two things that if we can get this to happen, could be areas where the disability groups could really play an important role.
We have time for one
Yes.
question.
Oh, my question was actually about this prioritized list. I'm wondering, I mean, they've had such success in Oregon, and I'm just wondering, who gets to decide? I know it's the legislature, but I mean, is there like a commission? Is there a panel? What are the,
And how to start prioritization in Michigan?
yeah,
It would be a legislative act. It have to be done by the legislature to authorize the bureaucracy for the state to set up this system. And I tried to get a copy of the Oregon bill back in 1891, 1991.
you look great for your age, by the way.
And I couldn't get anybody to send me a copy of that bill, but that's where I would start.
Thank you.
Well, unfortunately, it's 7 o'clock, and it seems like this could go on for a while, but I know some people have to get on the road, and I'd like to offer that it's been a terrific discussion, a conversation. Please, if you have additional questions, can we ask that you don't just take them home with you and keep them, send them back through the websites or back to the DAKC, just so that we can continue this and try to act on it. It's a huge, complex subject with no real answers, as Dave was alluding to. But thank you for the conversation. Thank you, panelists, and appreciate it very much.
If I could
You
just
all have a good evening.
offer a quick summary, there's an elephant in the middle of the room. There's going to be a shrinking of Medicaid dollars.
If we can do it on the website.
We've got to find means to fill that void for those persons who have disabilities. If we don't, there's very serious consequences. And we can talk about prioritizing plans and getting the legislature to do this. We as community groups, the call to action to me is start bringing in other community groups, start bringing in the faith-based group organizations, and prepare for what's going to be a desert.
Yeah, I think you've hit on a big question that it's one to go home on. But I know as an individual, and I know a lot of people, we just don't know where to go to mobilize, other than a congressman or senator's office or an organization that's already waving some banner saying that they're doing something about. But certainly, the call to action is to get involved, some way or somehow, to make a difference.
Picking up on your point again about the employer groups, the Michigan Chamber, the Grand Rapids Chamber, Small Business Association of Michigan, Business Leaders from Michigan, and Michigan Manufacturers Association all endorse prioritization.
Okay, great.
We're working. we may actually have the alignment that we've been trying to get for years, where we have the right people in the right places. It could happen.
Let me close with this. There is the DAKC website. There's a survey on it about the conversation tonight. If you can provide any feedback to that, it'd be much appreciated. Any suggestions? This is all on video now, so we've got what Carl just ran us through, but we're all looking for a way to make a difference in this complex matter. And it sounds like there's 1,000 needles in the haystack as opposed to silver bullets. So thank you again, and appreciate your time tonight. Thank you.
Thank you.